Okay, let's go ahead and get started. We are recording and broadcasting. So welcome to our case conference today. We're glad to have you here, and hope we have some fun looking at an interesting case. This gentleman is a 65-year-old male. We see quite a few people from Trinidad, and he lives in Tampa, and he came to see me for a second opinion in August of 2010. The nice thing about knowing it's in August of 2010 means that we have 6-year follow-up. And so that's important to have some longitudinal follow-up. As you saw one day, we gave you a 40-year follow-up. We also had presented a case previously on someone who had a transplant with a 30-year follow-up. And hopefully this year we'll have a 31-year follow-up on that gentleman. And so this patient had symptoms consistent with congestive heart failure at night, only at night. And at night he get in real trouble. Couldn't lie down flat. He had to sit up on a chaise lounge to sleep. Multiple pillows, but have shortness of breath all night. Had some pedal edema, and he was very miserable. He did not have chest pain or other of those symptoms that I've listed. He does have a history of having bypass surgery remotely, and we'll get back to that soon. So he had a chest x-ray that was normal, and he had, this is some of the old stuff that basically got him to where he is now in terms of moving towards bypass surgery, which he had already had. And so he had an echocardiogram that showed dilated left-sided chambers. His ejection fraction was good, 60%. He had some moderate mitral regurgitation. Had coronary calcium score. I'm not sure why they were doing calcium scores on him, but I guess they wanted to decide if he had heart disease. And so, hey, that looks like he does have heart disease. He's got a calcium score that adds up to over 1,000, so pretty good chance that he does have some obstructive disease as well as coronary calcification. All bets are off as to whether this is a one-and-done situation and whether he has any vulnerable plaque or non-calcified plaque or not, because we don't know that about him because all he had was a calcium score instead of a coronary CTA. So let's look some more and see what we can find out about him. Well, he had our own enemy, the SPECT scan, 2008. We'd been doing coronary CT instead of SPECT scan for about 4 years by then, and so we were no longer tied to SPECT scan. We'd also started doing PET scans in 2006, so we're no longer tied to SPECT scans at all. And so in his SPECT scan, he had ejection fraction of 45%. There was some prior infarction, they thought, of the inferior lateral wall, but who knows? I mean, that's a SPECT scan, and so we can't say much about it. If it has a 40% false positive, 65% false negative, we can't take this to the bank like we used to. I'm not taking that to the bank. And he had a cardiac catheterization, which we will show you here in just a minute. Hang on. And you saw his heart running backwards there for a minute, but now we're going forwards again. And so there's the right coronary artery, which is totally occluded. There's a bypass graft to the right coronary artery. There went his hand fleetingly went by. There's the filling of a circumflex branch that's filling by collaterals from the right coronary, big old circumflex branch. There it is, big old circumflex branch filling, and there's the occlusion of the circumflex. And this is a septal perforator of the LAD, and then occlusion of the LAD, and then calcification of the main left ventriculogram. Look at that ventricle, it looks pretty good. A little inferior apical hypokinesis, and we can slow this down. I like to do it fast, but we can slow her down here for you. There's the LAD filling by this big lima is filling the LAD. It looks really nice. Filling a diagonal too. So I slowed it down for you. There's a vein graft to like an OM1. And there it is again to the OM1. Little tiny vessel, not much to it. Here we go, filling the lima again. Big lima. There's the right, totally occluded, and a few little things, and there goes his hand again. And so we're showing everything twice. And so the important thing to note here is there is an occluded distal circumflex that's, well, not so distal, including circumflex that's filling by collaterals and everything else looks like it's been pretty well revascularized. And I guess there was an attempt to revascularize the circumflex, and all they got was that little tiny dinky first marginal vessel, and that was all that was really bypassed. There's again a big collateral coming in here, filling this vessel backwards, and this is this little dinky first marginal vessel that fills by this vein graft. And that vein graft, I don't think that's going to stay open very long, because it's not going to much circulation, and if it doesn't go to a big vascular bed, they don't stay open. There's the distal and the proximal right. There's some more of the right, and filling of circumflex circulation, retrograde, more filling of this big retrograde vessel up here. And there's where the circumflex ends. It's kind of patchous before it ends. That might be an example of coronary ectasia. And left ventriculogram again. There's the wires from the previous surgery. You see the sternal wires. Here we go. Filling this collateral over here is filling big collateral. As we fill this vessel, we fill this big collateral that looks like some more of the circumflex circulation filling by collaterals. And so a lot of anatomy to see here. There it goes back there. Not sure if that's a D1 or if that's some OM that's filling by those collaterals. And so maybe that same vessel we're seeing over here. Okay, so we're going to stop this. We've seen this, and let's go back to our slides. And so our cardiac catheterization showed triple coronary artery disease, occlusion of the LAD, occlusion of the circumflex, occlusion of the right. So very bypass dependent. And then a patent lemma to the LAD. LAD is totally occluded. After a septal perforator that may have a little bit of disease in it. 50% left main, which doesn't really matter because it doesn't go to much circulation. Saphenous vein graft to the tiny vessel that may have been one of the OMs, and that graft had some disease in it. It's not going to stand up the test of time, I don't think. Patent because it's so patchous and it's not going to much distal circulation. Oh, that's a radiograph to the PDA. That's interesting. That's a big radiograph that was picked up from the left radial artery and brought in, so that's a very nice arteriograph from the PDA. And then collaterals from the PDA and the distal LAD to other circumflex vessels filling retrograde, and some hypokinesis of the inferior wall towards the apex, a little mitral regurgitation. Ejection fraction is not very bad, and so it looks pretty good. So basically, this is interesting. He was told by his physician that in his current state of congestive heart failure during the night, during the daytime, he's much better off, that basically nothing can be done and everything is revascularized except for the totally occluded circumflex, and the occluded circumflex cannot be opened, And I don't know if that means I can't open it, and no one else can, or people can open it, but I can't. But it said, can it be opened? And so basically this gentleman's on maximal medical therapy, and that's it. He is going to be in congestive heart failure the rest of his life, whatever limitations that might put on him. And so, Pooh, would you like to make any comments about what you've seen so far?
I didn't see his med list, but yeah, definitely we need to fix the CTO or see how bad that MR is and if we can do something about it.
Like your optimism. How about Melody? Is anybody over there that would like to make a comment at Largo? I don't think Largo has a mic, so. His son came and got him, and we were working together in something called ISIS Healthcare, and his son is in charge of IT, and so he said, I'm taking you to Dr. Harrison. We'll see if there's any other alternatives. And so he came to see me, and these are the findings. And as this is, his heart rate was 78. That's kind of fast for somebody on medical therapy and congestive heart failure. We usually have them beta blocked and we have their heart rate a lot slower than that, so that's kind of surprising. Blood pressure is good, 134/76. To have that kind of blood pressure to be able to work with and with medical therapy is excellent, because when somebody comes to see you and they got a blood pressure of 98, you can't really push a lot of beta blockers or a lot of ACEs or ARBs or Lasix when you got a blood pressure like that. His BMI is kind of high, and so certainly he hasn't lost much weight. He doesn't have cardiac cachexia for sure with a BMI of 35. And we saw that he had a peak expiratory flow that was pretty reasonable, because we gave him a peak expiratory flow meter while I was talking to him. So COPD doesn't seem to be much of a problem with him, and so that was good news. And then he has a systolic murmur. No JVP when I saw him. That's kind of amazing, given his symptoms. Breath sounds were good. No clubbing. Nice pulses. So no edema. So what I was seeing looked pretty good. Certainly out of proportion in terms of equilibrium, out of proportion to that of what he is expressing that's going on at night. So what to do next, Pooh? Would you like to see anything?
We'll start off with the EKG, then X-ray, then echo.
Pooh has called for an EKG and echo. So Pooh, what do you think about this EKG?
There's some PVC, but let's see, sinus. There's like atrial abnormality. There's bifid, like left atrial enlargement. Other than that, QRS voltages in the limb leads are kind of short, small, like less than 5 or right about 5. So low voltage QRS at least by limb lead criteria. R-wave progression is very poor. So it looks like he's had some maybe prior infarct.
Okay, that's good. Well, let's take a look at his echo then. And so we've got a lot of prominent voltage, and we've got this big negative wave in the P wave towards the terminal part of the P wave, and the P wave itself has some prolongation of the P wave, not the PR, but the P wave. And so it must be a big atrium that it's traversing to have a prolongation of the P wave, and then poor R wave progression, as she called. So that looks pretty good. So doesn't look really bad. Don't see a lot of big infarcts and stuff anywhere, unless this represents a septal infarct. So let's go take a look at the echo. Hang on. Echocardiogram, Pooh. We've got some hints up here. There's some hints on the report up there. So I put the report into rapid vibrate, so you can't read it, okay?
There's some MR with Canada effect. There's hypokinesis. Let's see. It's like the basal area is not coming in. Or base, yeah, the basal lateral wall is not coming in as good. And again, we see this MR, which is like moderate to severe range. It's almost like hugging the wall, so it has to be that.
If they go faster. There we go.
Yeah, the posterior wall is not coming in as good. RV looks a little bit on the bigger side.
And so we can go back to the slides here. So you want to summarize that a little bit in terms of the cardiac cath you saw, and then in terms of the echo and the EKG, how does all that fit together, Pooh?
So that's like lateral, intralateral hypokinesis and basal hypokinesis. There's moderate to severe MR. LV cavity appeared a little dilated. And right side, at least in some views, looked a little big.
So what can be done? Is it true nothing can be done? No one can do anything?
I mean, if he's symptomatic, we do need to do something. I need to see his med list. Obviously, we'll optimize that and then see if we can do either like do something with the circ, or at the same time like do annuloplasty or do something for the MR.
There's your med list without dosages.
How much beta blockers is he on? His heart rate was up. How much Lasix?
I have that for you in just a minute here. We've got carvedilol 25 BID, clonidine 0.1 PRN, or once a day. We've got furosemide 80 milligrams in the morning, potassium 20 milliequivalents BID, Crestor 5 milligrams in the PM, Iserdil 60 milligram mononitrate, nitro patch, Norvasc 5 milligrams. That's pretty much some Zeroxylin 2.5 milligrams, 30 minutes. Oh. Like a lot of medications, Moving right along. Okay, we have the echo we talked about. And interesting, the RV systolic pressure was normal, which you wouldn't expect in somebody who's having episodes of pedal edema. We've got, moving on next, what would you do next? And so here we are for the next question. Pooh, what do you think our options are here?
Well, I saw the next slide, the PET CT.
Goodness, you're observant. And so we're going to do a PET. So this is interesting because that's not really an option in most institutions. And so to have that as an option, everyone really has it as an option because Dr. Gould does those superbly in Houston, and I may have one or two people flying Southwest Airlines from Tampa to Houston. They land in Hobby. They take a cab up to the Weatherhead Center at Herman Hospital, and they're scheduled to have their PET. It takes 23 minutes to do the test, and then they meet with Dr. Gould for an hour, and then they're back in the cab, they're back on the plane, and they're heading back home. So Dr. Gould has used $100 million of Houston oil private donor money to develop the best software in the world. It's so good that I can't even replicate it, and he said I could use it, but I can't use it because my crystal saturates too fast, and I would have to buy a whole new system to be able to do that, which cost a lot of money. And so I said, well, why don't you people just take a plane to Dr. Gould? But we did do, since 2006, I think we've done about 3,000 PET scans here. And so we will show you a PET scan and talk about that. The PET scan that I do uses rubidium 82. The PET scan that Dr. Gould does usually uses rubidium as well. Sometimes he can use nitrogen and uses NH3 ammonia. And so let's look at our PET images and see if this helped us any. And so what we want to know is there dead muscle or is there ischemia in that circumflex circulation? What is it that's compromising the papillary muscle? Is it the anterolateral papillary muscle that's being compromised, or is it the posterior medial papillary muscle? The anterolateral is supplied by usually OM1 or ramus or D1, or maybe two of the vessels will supply it. The posterior medial supply, usually the right coronary artery, maybe a distal right from the posterior descending in the interventricular groove, or else it's supplied by NOM3. And so we've got these images to show, which are rubidium, and there's a big blue spot surrounded by green. And so the whole thing, everything else looks pretty homogeneous. And so the question is, this is rest, this is stress, and what's the big blue spot? And this is subtracting rest from stress, I think. Yeah, it looks like it. And so what's this big blue spot out here, and what does that mean? And so, Pooh, would you like to comment on the fact we got a big blue spot over here that looks like seems to have something to do with something wrong?
Yeah, that looks like it might be ischemic because the uptakes, I haven't seen too many PETs, but I'm going with like that area could be ischemic.
So we got this area that seems to be pretty large of decreased blood flow at rest, and so and then we have that's the umbra, and then there's a penumbra, which is decreased blood flow during stress, and then we subtract one from the other, and we get this surrounding area here. And so so you might call this hibernating myocardium, because all we know is there's decreased blood flow. That doesn't mean the muscle's dead. And so how would we do a PET to determine that? Is there something else we can do, Pooh?
We could, like, there's decreased blood flow to kind of confirm it.
Well, we've got a rubidium flow study, but we don't have a metabolic study. And so what we would need would be an FDG metabolic study. And if we find that there is a mismatch, yes, a mismatch. If we find that there is no flow, but there's metabolism of sugar in that area, then we would know it's not dead, it's hibernating myocardium. And so that would be found by doing the same study, but not using rubidium, and you really wouldn't have to use stress. You wouldn't have to use Lexiscan or Persantin. You can just give them some FDG, and you make sure that you give them, get their sugar up to increase their insulin, because you want to switch them from free fatty acid metabolism to glucose metabolism. And the heart normally metabolizes free fatty acids mostly. So if we switch them over by giving them some insulin, increasing their sugar, give them a sugar load, give them some insulin, then they go in FDG metabolism or glucose metabolism. They'll take in the FDG, and it'll get phosphorylated, and they won't be able to break the bond and get it back out again. So it will be intracellular and show that it was taken in, which means there's active transition. It's actually moving it in, active transport, not passive, but active, which means the cell's alive. And that's what we did. And we found that this area, and I can't show the images, I'm sorry, we had a problem delivering images from PAC to the Sun workstation, and so I can't show those, but I can tell you what it showed, and it showed that this area was totally active and totally orange then. So it was a mismatch in that there's decreased perfusion, but there's normal metabolism. So that means that the heart muscle in that wall is alive. And so we had no chest pain, no ischemic changes, dilated left ventricle. The ejection fraction actually dropped from 64% to 38%, which is a bad finding. Means there's some problem. When we had some reversible lateral wall defect, there was a fixed apical septal, which may just be some left ventricular thinning, which is transient ischemic dilatation. So what to do next? Pooh, what would you do now?
MR, CMR, to kind of make sure what's dead, what's not.
Certainly CMR is a nice, reliable information for finding out if you got dead tissue with late gadolinium enhancement. And so being fluid with all of these imaging modalities, it's very important. I think that we're confident with the PET, and the PET told us what we need to know, so I think we're ready to move on. So we did do the PET, and we did find viable muscle, and we're ready to move on with this cardiac cath again, and perhaps we can open up this target vessel. So let's take a look at that. Nobody can do anything. Let's see if anybody can do anything. So this is Dr. Stromquist in the cath lab. Well, he has a wire down the circumflex, which is our target. And we have and so we are seeing this vessel down here, and we're trying to get into there. We've got a balloon up on the side. We got another wire on a side branch, and inflating the balloon in several sites. And we're starting to see vessel starting to open up some. We got more balloon inflations. Starting to see that same circulation that we saw filling retrograde, which means that it was protected, wasn't giving enough blood supply to cause the area to move or to cause the area to get much perfusion on a perfusion study, but it was giving enough blood supply to keep it alive, and now we want to get enough blood supply to get things moving again. So we got a long balloon going there. Oh, look at that vessel. It's starting to look pretty good. We're starting to get towards the end stage of this procedure, and we're starting to see something that we wanted to see, and that is we're opening this up. And here's another image. So what do you think now, Pooh?
It looks great, so hopefully we feel better. We can get another echo in a little bit to see how bad the MR is and if DFs pick back up again.
So we did at the time of cath, with right and left heart cath, we did find that the RV systolic pressure was 70 millimeters of mercury. The main left wasn't revascularized. We found all this stuff, and we got that circumflex opened up. The patient basically was asked about mitral surgical repair or mitral valve replacement versus a functional mitral valve work to try to open up the graft, electronically occluded circumflex, not the graft. And so he elected to do that and to give that a try rather than have a second open heart surgery, which would be brutal for him. And you see we had backup catheters, we had total occlusion, we had chronic occlusion and the circumflex, and it was opened up really nicely. There was a long stent. A 28 millimeter drug-eluting stent was placed. He did well and tolerated it well and went back home. And basically on follow-up after that procedure, follow-up a year later, 2 years later, 3 years later, 5 years later, and now 6 years later, he's doing very well. And we have done a follow-up echo study, and we see basically an area of infarct or damage, but we also see ejection fractions in the 50% range, and we also see that there's much less mitral regurgitation, and so we're really happy with that. So this was a successful outcome in a gentleman in whom all hope had been abandoned. And basically he was condemned to a life of sleeping in the chaise lounge at night, short of breath, taking oxygen. During the day he could walk around. Night he'd get his symptoms mostly with pedal edema and mobilizing a bunch of fluid into his lungs, and to his dismay. And so that's interesting because the papillary muscle, as you know, the anterior lateral is supplied by the D1 or the OM or ramus, and the posterior medial is supplied usually by a right ventricular branch, maybe the posterior descending branch of the right coronary, but also can be supplied by the circumflex if it's a dominant left circulation. And so we need to talk about nothing can be done. And I'd like to come to some understanding of what does that mean when a patient is told nothing can be done. Does that mean I can't do whatever needs to be done and charge for it because that's not in my skill set? Does it mean if I send you to another doctor and she would keep you and I'll lose my patient? I don't want to lose my precious, even though my patient's at home miserable. Does it mean I don't know another doctor who can do this procedure? Well, it's pretty well understood nationally that William Lombardi is a specialist at Seattle who goes around the country putting on seminars to teach people how to open up chronic total occlusions. And then there's Dr. Heuser, Rich Heuser in Phoenix. There are people that specialize in chronic total occlusions, and they put on their shows at the American College of Cardiology, American Heart Association national meetings. Doesn't mean I don't know the pathophysiology, therefore I can't offer any other than what I'm trained to do, and I sort of can't figure that out, or does it mean I'm trained as an interventionalist, which is called a C-level cardiologist, and interventionalist cardiologists can get paid by Medicare now. At the same time, the patient's seeing a non-interventional cardiologist. Both can bill, and they've been established as separate specialists, and they have separate billing categories. But I'm in practice as a sole practitioner, and I have to work up patients to find the arteries to stent because I don't have non-invasive cardiologists to refer to me. So that may be that I'm not part of a system. I'm not part of a pyramid that patients are referred up to me. For example, I have to be the quarterback and I have to be the receiver. So I have to throw the football and then I got to run downfield and catch it. And so I'm looking for patients, and I've got to do all these tests, spec scans and so forth to try to find somebody that I can take to the cath lab and do what I'm trained to do. Or does it mean I don't send patients to advanced cardiac imaging specialists to do PET scans to find out the story? Or does it mean I don't know what a PET scan is and that it could help me, or I don't know what an MRI is, or, hey, well, we know Dr. Gould is the father of coronary blood flow. So does it mean I don't send patients to Dr. Gould because I talked to Dr. Gould and he's internationally recognized in what he's able to do, and you don't have to worry about him keeping your patient because he's in Houston and you got to catch a plane to get there and catch a plane to get back. And so maybe you think the insurance won't pay for it, Bob?
Well, this is far more a social economic issue than a medical issue.
And so how do we do it?
Well,
do we provide incentives for referring patients?
It seems to me that Medicare has many pages about incentivizing referrals. That, this cannot be patient brokering.
So that's against the law to broker patient. Oh, Robert.
Well, I'm going to throw one off the wall. I'm intrigued that this guy's symptoms were so heavily present at night. And yes, there is the midnight ride of the extracellular fluid. But we didn't do a sleep study. This guy has a lot of body mass, and his crumping at night may have been secondary to sleep apnea, at least partial, with increases in blood pressure and decreases in oxygen availability.
And you're right. There's no question that can precipitate his and compound and aggravate the pre-existing ischemia of the lateral wall. and the papillary muscle dysfunction. There's no question that that can be a co-contributor, and certainly doing something about his body mass would be important, and certainly assessing him with sleep study would be very important too. That's a good point that you pointed out here. Let's ask again about, you know, we sort of hit our head against the wall. We're interested in the nurse navigators understanding if they're following congestive heart failure home and then they're seeing them readmitted to the hospital, what are the treatable causes of congestive heart failure? And how do we sleuth that out? And how do we do something dramatic like we did with this guy, where he could have multiple hospital admissions easily for his congestive heart failure if he just dialed 911 at night when he got real short of breath? How do we sleuth this out and do the so-called cure, where the guy is fine now, and he's very happy with what he's doing, and he's very happy with his life, and he comes in here and hugs me every time he comes. And what is it when a doctor says there's no alternative? You saw the presentation that I gave of the patient who had conventional midline sternotomy and who had a very laborious workup with mitral regurgitation, with left atrial myxoma, and one was in the hospital for 20 days and came home in a wheelchair and came to the office in a wheelchair, and the other was in the hospital for 3 days and had a workup as an outpatient and had robotic removal of the left atrial myxoma, and came home walking in the office. And so there's such a difference in the kind of care that is available. The same insurance company pays for it. It's the same price, but you can get the best in the world or you can get the worst in the world. And or you could get the best diagnostic studies, or you could get jaded diagnostic studies that are legendary in terms of false positives and false negatives. And so is it we're not on the same team, and we're Americans, you know, we like to we're rooting for the Bucks, or we're rooting for the Lightnings, and you know, is that this kind of thing? Is it I might lose my patient, you know, it's my precious, like Gollum, my precious, or I won't get paid, you know, and if I put the patient in the hospital, I get paid $55 a day for a patient visit and maybe $250 for a workup. Is that so important? Even though your patient's going to suffer and your patient may die? Is it I can't take care of you there if you go to Greenville, North Carolina and get robotic surgery, and I feel really attached to you and want to take care of you? Or I don't know them there out there, you know? Or I don't do that kind of surgery and I don't send patients anywhere else but my team. What is it, Bob, that do we need to incentivize patients getting referred to the best procedure, to the best, instead of, how do we do that? How would you suggest that?
Basically, what I would do is provide a conference approach. You know, we commonly have cardiac surgeons and interventionalists discussing the cases and trying to figure out what an optimal approach is within the resources that they can cobble together. You know, this needs to be at an organizational level above the cardiology/surgery level.
That's a great idea, and I actually had a cardiac disposition conference at Tampa General, or maybe with my colleagues and with some leading hemodynamicists, and the patients, the cardiologist who was the invasive cardiologist would suggest, let's present the patient at conference, because we had a lot of heated dialogue with cardiac surgeons about whether the patient is operable, what's the best thing to do. And so the disposition conference actually was, there were minutes taken during the conference, almost like a court recorder, and that was subpoenable data. and we all discussed openly. And it also could be made, I would go talk to the patient and tell my patient, we're going to present you at our conference today. And then sometimes we'd even invite the patient if the patient was interested in coming, and we'd have the patient stay. Sometimes we'd even examine the patient during the conference if there were pertinent findings on the physical exam, or we would basically talk to the patient and ask them, prompt them to give their history. And so it turned out that at the end of the day, we would make a recommendation, and there'd be, maybe we would even vote, and there might be, like the Supreme Court, a majority and minority opinion. And then we'd get follow-up at a later time. And I remember warning the surgeon that we shouldn't do this patient with severe aortic regurgitation because he was asymptomatic, and also because he had a huge septal perforator that had a stenosis in it. And I said we could infarct the whole septum, and it's not bypassable. And so he did go to surgery, contrary to my wishes, and he did have his entire septum infarcted, and he did die from the surgery. And I don't want to say I told you so, because we want to keep that from happening. And so we had very vindictive conferences between cardiac surgeons and cardiologists as to what to do, because of the surgeon pulling the patient, and we were pulling the patient away from what we thought were the jaws of death sometimes. And so, but it was very interesting, and it certainly was academic, and it certainly did result, I think, in people paying attention to what they did and understanding there were more options in the world. Now, sometimes that kind of conference does become incestuous, and if you're in an institution that pretty well has closed walls, and you've got one cardiology group that has a contract, and you've got one surgical group that has a contract, and you're presenting, there's no dispute. Everyone says, fine, fix it, blah, blah. And so frequently it results in, no outside contribution and no cross-fertilization, and people are wearing blinders and don't feel that there's any other option in the world other than what they have in their center at their little village hospital that's not a maximal referring center, but just as a little village hospital with 2 cardiac surgeons and 3 interventional cardiologists. So, but that's a very good idea, and I think that can be, if there's an open staff with people of different persuasions that have different ideas, I think it can be very fruitful. And if there's data that's taken and recorded that's subpoenable, and if that's shared with the patient, I think they'll see there are other options. I think that's a real good solution. Janet, do you have any questions or suggestions, Janet, about what do we do when a care assure nurse comes across a patient that keeps coming back to the hospital and she thinks there's something that might be able to be done with this patient?
Well, I think that the first thing the nurse might do is reach out to the cardiologist who's attending that patient. Many of our hospitals in West Florida do have exactly what you discussed, interdisciplinary case conferences, and I actually put that in place myself when I was a CV leader. And we had cath conferences, we had M&M conferences, where you had the multiple cardiologists from different practices, multiple surgeons from different practices. We have, they often have the GME participants as well, and there can be a lot of discussion around the patient's optimal therapy, or according to what the guidelines may recommend from the various disciplines. And ultimately, at the end of the day, our goal would be to give that patient with complex disease, maybe, or comorbidities, the best option for treatment. So that's really in his best interest. And so we're very supportive of that. We do have the opportunity to do that at a lot of our hospitals. And certainly the nurse could reach out to that cardiologist to say, we do have case conferences here. We do have interdisciplinary teams that will evaluate a patient as a panel, and could discuss that. The nurse navigator can't refer that patient to an additional physician without the onboarding and agreement and recommendation of their attending physicians. That's the one thing that care assure nurse navigators can't do. They can't really affect where that patient gets referred. They have opportunities to educate the patient about what options might be out there. But again, as far as referring to a different physician, that really needs to be discussed and come from the attending physician. It's a tricky place to be.
Yeah, so from time to time we're going to present these cases that are congestive heart failure that are reversible if you can recognize what the problem is and what you can do. And we want the nurse navigators to have the opportunity to be able to recognize this that may be unrecognizable by others, and then to be able to talk to a doc to see if we can make some change. Because, you know, it's very difficult to make change. And as I've said before, it took 17 years to get 60% of doctors to give an aspirin for a heart attack. And we said, what's the magic about 17 years? And the magic is that the attrition rate for doctors is 6% per year. Those are disability, retirement, whatever. And so if it's 6% per year times 17 gives 102%. And so we replaced all those doctors in 17 years, and that's how we made the change, was to replace them. And so that's very interesting and very telling on our profession in terms of how we sort of get set in our ways and remain and are not subject to making the changes that we think might be important in our system. And we're hoping to be able to work with Linda Carter and work with Peter and work with the nurse navigators, work with the cardiologists in the hospitals, and to take advanced cardiac imaging and bring it into the other 15 hospitals in HCA West Florida. And so we've got an assessment of what kind of CT scanners they currently have, an assessment of what kind of MR they currently have. And as we did, we took our CT, MR, and PET, and we just added a piece on to each one of them, or maybe two pieces, spent a little money, and upgraded each piece of equipment to do cardiac. If we can do it in our center, we can do it in other places. And so, as you know, there was a big move to do cardiac CT about 12 years ago, and that's when it became known in the literature. They have 64 slice scanners, and so everybody went out, all the hospital systems went out and bought 64 slice scanners and put them in the hospitals around their network, through their networks. And so, but nobody used them because there was no reimbursement. A lot of guys went out and learned, because I went around teaching, and I would have 20 cardiologists or 15 cardiologists, and I'd have a class for a weekend, and we'd get them to level 2, and we'd train them to read coronary CTA, and we'd line up a bunch of cases and do 27 cases in 2 days, and they would get everything they needed. But there was nowhere to go with it. There was no reimbursement. The insurance companies were counter to that. They drew a line, and they said, anybody who crosses into PET, CT, and MRI has to call us and say, Mother, may I? Because we don't want that to be an add-on procedure. We don't want them to do a 6-pack, which is a history and physical, EKG, echo, and then SPEC, and then cath, and add on to the 6-pack another test that every time a cardiologist touches a patient, it's $7,000. We don't want it to be every time a cardiologist touches a patient, it's $8,000. So they drew a line, and they said cardiology is going to go out, and they're all going to buy CT scanners and put them in their office, and they're all going to crank this out and make more money. We're going to stop that. So they stopped it by contracting with radiology benefits managers to not allow the test to proceed on. And so that stopped the whole thing. Well, the problem is that now that we've proven the benefits of these procedures by publishing medical literature that's become very solid now at this point, those large hospital systems got burned 12 years ago, and so they're saying, we're putting more CT scanners out, but they're for radiology procedures, and we're not going to add on the coronary package. And we'll put 2 in the ER in Brandon, or we'll put 1 in a freestanding emergency facility, a 32 slice, and we won't put coronary packages on the 2 in the CT scanners in Brandon in the ER, because nobody needs those anymore. It didn't work 12 years ago, So we're not going to make the same mistake. But unfortunately, you're fighting the last war, not the new war. And the new war is that this has become documented to be a very efficient way to evaluate patients, both in the hospital and in the emergency room. Increases your emergency throughput, is cost effective, saves a lot of money, and actually, instead of being the $7,000 with the cardiac six-pack, you decrease the cardiac six-pack and actually spend maybe $1,000 working up a patient and sending them home safely, knowing they're not going to have a heart attack. You pre-select those who really need a cardiac cath, who have 3-vessel disease. You select the CTOs to open up, and your cardiac cath rate of negative disease in the cath lab falls from 60% to 21%. So it's a reasonable thing to do, and we need to all let everyone know that, that this is a reasonable approach. Any other comments from anybody? I think we can wrap it up. Yes, Bob.
I would add in the input of the cardiac anesthesiologist. The cardiac anesthesiologist is beat by beat involved in that whole physiology balancing game of driving this patient with one engine through the Himalayas. So they often have very, very sharp skills at physiological acute interventions.
Absolutely. And my experience, my great experience with the cardiac anesthesiologist is when we had the patient with a pheochromocytoma and we're going to do the resection, and we got a nielsen-ephrine drip and we got a nipride drip, and we're bouncing back and forth between them. And so very impressed with the cardiac anesthesiologist. Thanks, Bob, for telling us about that. Thank you, everybody, for attending.
Harrison, this is Janet. I just had one other comment. I think that I think the nurse navigators that we work with here have an opportunity to educate patients about their disease and their disease process and their opportunities. That being said, your commentary about the CTA, and I'm very aware of all of that, with increased guidelines and literature recommendations about the appropriate screening, the appropriate use criteria that are in place related to cardiac catheterizations and PCIs, there will eventually occur a shift, I believe, to perhaps more non-invasive testing. But certainly it's something that needs to start with the cardiologists who are willing to refer a patient outside their immediate network to get a complete evaluation. And that's something that I think is going to take some time to shift.
Yeah, even the state government, Florida, doesn't recognize CT as being a cath equivalent. And so if you want to get a license to do angioplasty, you have to demonstrate 300 cardiac caths in a year. And so basically, if people were doing coronary CTA and they want to drive for that license, then they'll shift the CTA patients to being cath patients.
And I believe it's increased. I believe it's increased to 400 a year.
Yeah. So those who are haves are trying to keep the have-nots out, and by doing that, they're subverting the system because
a tricky space. I agree.
Yeah, exactly. Thank you so much. Thank you, everybody. Look forward to seeing you next week. Bye-bye.
Thank you. Bye.
Hi, Janet and Robert and Christine and Mindy and Pooh, Sharon, Teresa. Thank you, everybody.
Thank you.